All right, so like I said, well, it was like a week or two ago that we did the kind of like overview of the MBLEX and kind of broke down the categories generally and listed some topics and study points. I want to go through and actually break down each individual section on its own and kind of go over just the mass amount of details and really highlight some of the finer points that you might expect to see in regards to the MBLEX. So first, let's take a look at the listing of what the MBLEX indicates is contained in this category, which includes the organization of a bodywork or a massage session. So we can probably gather that's going to be the progress of a massage routine, all the components of a massage routine. So we'll break that down. How to consult and how to evaluate your client's health history intake form, and how to essentially perform a proper procedure, which we'll probably also see parts of that as well in the ethical side of like how to interact and be professional as well. But this will probably be more likened to the clinical side of that aspect. Of course, we're going to look at writing and recording the health history information or session notes with your client. So we'll look at some SOAP note documentation. We'll definitely look at the assessments here, mostly as it labels here, some visual assessments, which includes a general assessment, a palpatory assessment, postural assessment, gait assessment. Palpatory was the next line there, so palpation assessment, the assessment through touch, and then of course range of motion assessments as well. So we'll look at some pretty good and in-depth listings of some of the different assessments that we'll be performing. And then the last category is clinical reasoning, which it lists some suggestions about this, which is the ability to rule out contraindications, how to set treatment goals and how to build a treatment plan, evaluating the responses of the previous treatment, so kind of basing your current session off of the results of the previous session and how the client came in and responded to that, and then the formulation of the treatment strategy. So let's go ahead and start knocking all of these sections out one by one. So first up is the organization of a massage and bodywork session. So first, what do I think we might be able to see, or what components that we find in our program might be relevant and worthwhile to really focus on and look at in regards to this topic. So of course, like we said, it's the breakdown of a massage routine. Understanding all the aspects of what a massage routine entails, what makes a massage routine, good and beneficial for our clients. What are the components of that? What are the qualities of a massage routine? Alongside that, we have the concepts of pressure. So we'll kind of go into a rabbit hole about pressure, why it's good, what from a neurological standpoint, why pressure is, beneficial to our clients. Of course, we'll focus on, thinking about the way we flow with our strokes, focusing on blood and lymphatic flow and how that benefits our clients in a bodywork session. And then considering area prioritization and using some of our neurological laws to help justify some of those means. All right, so everything in that category essentially lines up to how we structure a bodywork routine, a massage routine. So just as an overview, our routine consists of several factors. One, the depth and level of pressure that we perform with our techniques, the direction and the length even as well that our techniques travel along our client's body, how fast we perform those techniques and the patterning in which we implement those techniques, and then our time management and how we can essentially piece that all together. So if we can break all those components down and understand them individually in regards to how this is beneficial for our client and why these make our massage routine great and beneficial. So first is pressure. And let's just understand briefly the depths and idea and concept and levels of pressure, which, so there's lots of ways you can justify or split the hairs in a sense of pressure levels. You know, some people say on a scale of 1 to 10, what's the pressure like? You know, when you're asking your client what kind of pressure they might like. And of all of the justifications and all of the proposed ways of explaining pressure, I like to look at something very similar to as displayed in this picture here, which is more of an anatomical depiction of pressure. And we typically call it a 7-layer approach, which is that essentially our pressure penetrates 1 through the 7 different layers of the body. So what exactly are those layers? Just real quick. Well, of course, we can literally just be very on the surface of the skin, which we would consider the epidermis. And we essentially would just be like moving the hairs. The skin would have no tissue displacement essentially at all, but we would still be affecting the various nervous system receptors that are in the skin. Then, of course, we have the dermis, right, which is the layer underneath that. So now we could have actual slight skin movement and displacement, which is, I mean, in this case, it's extremely minimal pressure. Then we would have the superficial fascia and adipose layer of tissues where we can start to move things. So basically our pressure quite hasn't reached the layer of muscle tissue yet, but it's getting there. Then we would get to the muscle layers, which typically, you know, this particular description talks about deep fascia in there, but usually I say there's 1 to 3 layers in general of muscle tissue in any given area of the body. Now, obviously, some areas there's only 1 layer of muscle tissue. Some areas of the body there could be as many as 5. So it's just kind of a rough estimate, right? So typically, three additional layers of muscle tissue or other structures that you would be penetrating to where you get to the final layer of pressure, which is the bone. Your pressure could never exceed bone deep pressure, which obviously would you know, be pretty vigorous on most clients. And then depending on the area, could require a lot of pressure and force to actually reach that level. So first, let's take another concept of pressure, which is, you know, the procedure of pressure. So remember that in general, when we apply pressure, we always want to work from light to deep. Why? Because for a little bit of science, the connective tissue mostly, but as well as the other tissues have properties to them. But connective tissue, in a sense too, has a colloidal aspect, especially in regards to fascia and the other structurings of the various tissues. So in that sense, that colloidal means that it's suspended particles in a matrix, kind of like a non-Newtonian fluid, which is, if you've ever seen those videos or made like cornstarch, with water here, and I'll just take this down. If you've ever made like cornstarch and water, and you smack it really fast, it's kind of hard. It actually, the suspended particles lock, creating a harder structure. But if you rest something very gently on it, it'll sink through and into the fluid. So the same thing, right? You want to work through the superficial layers and allow those layers to, you know, essentially permit you deeper into the body. So we always want to work from superficial to deep. And then another concept I like to talk about with pressure is having a broader base and taking a slower pace. With that understanding, well, one, a broader base means that your point of contact. If I took 10 pounds of pressure and I put 10 pounds of pressure with a sewing needle into the palm of my hand or my fist, well, which is going to hurt more? Obviously the sewing needle. Why? Because it's the same amount of pressure, but it's that pressure will be distributed amongst a larger surface area, which can, you know, reduce the intensity of that pressure. Now, there is cases where we might want to be very super spot specific with maybe an elbow or a knuckle or something of those along those lines. But, you know, there's always a time and place for that. And then a slower pace kind of goes along with that previous point we just mentioned of maintaining you know, working from light to deep. So once we have that deep pressure, we want to go real slow, because if we go fast, we're going to cause tissues to react, protect, and spasm and splint and essentially lock up. So we don't want to do that. So we want to have nice, sustained, deep pressure with a broad base at a very slow pace in order to really benefit our client. And so here's just a few justifications of why that will actually be beneficial to our clients, which kind of goes along with these neurological components that we see here. So one, of course, mechanoreceptor responses. For those who may have forgotten, the various mechanoreceptors we find in regards to muscles are the Golgi tendon organ and the muscle spindle fiber. Now, the Golgi tendon organ probably not going to respond too much to massage load and forces, but inadvertently it may affect it because the Golgi tendon organ is found at the neuromuscular junction of the muscle, which is where the tendon and the muscle actually meet, or well, excuse me, where the continuation of the connective tissues on the muscle fibers carries on into a tendon to anchor it to the bone. That is where we find the Golgi tendon organ. And the Golgi tendon organ is responsible for monitoring the amount of tensile force present in a muscle, or excuse me, or to put it, to not confuse it with the other proprioceptor, the amount of load, we could say, the amount of weight bearing that the muscle is being placed upon. So yes, you know, we can inadvertently maybe petrissage around the musculotendinous junction, which you should, as it is pretty beneficial in that area, and it may cause some inverted effect. But it's mostly the muscle spindle fiber that we will probably see the most benefit from, or the most effect towards, because the muscle spindle fiber is the little coiled like spring-like detector wound around the individual muscle fibers in the muscle itself. And so think like a spring. If I took a spring and stretched that spring out, and I stretch that spring out really long, well, it's actually going to, I usually have a slinky here for this, it's going to get stretched out and then it usually snaps back. So that muscle spindle fiber is responsible for monitoring the length and how rapidly that length of the muscle is changing. And what happens with it causes what's called the inverse stretch reflex. When it's triggered, it causes the muscle to stop lengthening out. But by essentially triggering that proprioceptor to, you know, understand that the muscle is changing lengths, but not necessarily rapidly or in a negative manner, we can actually cause it to start to deactivate. And a lot of these neurological and a lot of these receptors will kind of respond in that manner, right? So we have this idea that the nervous system will deregulate its sensory perception in light of constant exposure. Whereas, so think like if I came to your doorstep and I started ringing your doorbell, ding, 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 obviously you're getting annoyed. So what are you going to do? Well, you're either going to answer the door and slap me in the face, or you could just cut off the doorbell so you don't have to hear the sound. So that's another potential justification of why massage triggering these various nervous system responses in excess can cause it to deregulate or stop the mechanisms or protective implements that they would put in place. So now when it comes to pressure, right? Pressure is always unique to the individual, and we always want to apply the right amount of pressure that they're comfortable with. But what exactly is the right amount of pressure that's going to elicit valuable responses? And in my experience and in my research, it doesn't take a whole lot of pressure in order to actually cause some of the greater benefits that we would see for our clients. Namely, because in the ways of myofascial release can be very more effective to work for the fascia and stretch and restructure and reorganize the fascia network as best we can than just straight pressing in and crushing muscles, right? And for several reasons. One is that the fascia is what typically gives all of those structures shape. Our muscles are shaped and are length because of the fascia and neurological receptors and stuff like that. But the fascia is what's typically depicting what the muscle is permitted to do. So if we can change that, then we change the muscle, right? And then, of course, these various receptors, namely right here, the Ruffini and the Pacini corpuscles, and as well as others, these are actually very superficial receptors. They're usually found within the skin that respond to deep stretch, sustained pressure, and various other things. But those two things we can use as our biggest justification of why, slow, sustained, moderate pressure at the surface level of the skin or, towards the first layer of muscle tissue can cause a lot of change, because these receptors have been proposed to have direct links of deactivating or deregulating the sympathetic nervous system, which, as massage therapists, we should be familiar that the sympathetic nervous system is the fight or flight response. And, that's one of our biggest jobs, is to deregulate the fight or flight response. And then we can look at, of course, the release of neurotransmitters, right? Dopamine, oxytocin, serotonin, endorphins and enkephalins, things like that. Our bodies will release in response to, the various relaxing responses that massage creates through the various means of engaging with deeper pressure, just general deregulation of the sympathetic nervous system, right? And so, of course, there is another benefit and reasoning behind that. So then we could take a look at Pfluger's law too. Mostly I'll use Pfluger's law as a justification of like time management and organizing of the body, but there's a few components to Pfluger's law that can really help us out, where especially like of unilaterality, where working on one side of the body can actually affect the other side of the body. So it's kind of an interesting component where we inadvertently can work on the non-problematic side and then go to the problematic side and essentially compound our work. So we'll take a look at that in a second. Now let's take a look at the direction and the travel length. So sometimes what we call direction or an excursion. So one, in regards to direction, we always want to follow the centripetal flow, which centripetal means towards the center. And this typically and generally applies to the extremities in most cases. But I can also say too that we always want to follow the flow of blood, or more importantly also lymph. So for that reason, when we're working on the arm, or the legs, we want to flow towards the trunk of the body. So just to also explain our lymph nodes, right? Where do we have lymph nodes? Well, we have lymph nodes, especially in regards to the arm. We'd want to push them towards the armpit, the axilla. With the lower legs, if we were working on someone's legs, we would want to push them to the inguinal region, or the, as I like to call it, the inguinal region. We have the inguinal lymph nodes. Now, of course, we also have within the arm and leg, there's antecubital nodes. So we can push, forearms into the crux of the armpit, or excuse me, crux of the elbow here, and then travel back up towards the armpit here. And then behind the knee, the popliteal nodes is another location. Now, other regions in which we have large clusters of lymph nodes, obviously our thoracic region is, essentially the central hub of the lymphatic system, where we have the two main ducts, the left and the right, the left being the more main duct of the body that are going to bleed into the, recycle the lymph fluid back into the circulatory system. But we also have cervical lymph nodes, kind of like the, around where like you think you're kind of like tonsil area, right? So you can technically think that in your normal massage routine, you might want to flow even on other parts of the body towards, or try to promote, or resemble lymphatic drainage flow. So now obviously you don't need to be trained in lymphatic drainage just to follow the flow of lymph. So you can so like if I was working on someone's chest, I would push it out towards the axillary nodes. If I was working on someone's neck, I would probably try to push them up into the cervical nodes. If I was working on someone's upper back, again, I would push them to the axillary nodes. If I was working on someone's lower back, I would try to push them towards the inguinal nodes. So just something you can kind of justify as beneficial for our clients, because, you know, following the flow of lymph, you know, it's just always beneficial, right? Because our lymph system is our immune system and responsible for, you know, cleaning our body. So why not promote the lymphatic flow? Now we can take a look at a concept of what's called transverse versus longitudinal strokes. So as we can see here in this little depiction, we typically will refer to this direction based off of the muscle fiber direction. So longitudinal strokes go along the muscle fibers. So we call this kind of like with the grain, right? So we're literally traveling in the same direction that the muscle fibers run. Then, of course, we can do cross fiber, or what's called transverse. Transverse means cross, so we typically call that cross fiber strokes or cross fiber direction. So in this case, going across the bands, or in this case, across the muscle fibers themselves. Now, both of these can cause various effects. So typically, our cross fiber effects, or a cross fiber direction, is going to create more resistance and create more, what's the word I'm looking for? More like rigidity, right? So we have the, like, if we take a look at or think towards like cross fiber friction, like the celiac friction, where we use this this resistance to build up this friction, to build up the inflammation in the area by following this resistance, right? Then we can kind of create a few different effects. Namely, if we look at, you know, think about the celiac friction, then, you know, we're creating this localized therapeutic inflammation, which is theoretically supposed to help cause and promote the healing. However, because of the, we'll say, I guess, aggressive or abrasive, I guess that's the word what I was looking for earlier, due to the abrasiveness of this technique, it actually can help to tone the muscle and build the muscle tone of the muscle as well. So typically what we call broad cross fiber techniques can most likely, and on paper, and right, not all of this is proven science per se, but to create you know, tonation of the muscle. Now, longitudinal strokes, you may think pretty straightforward. If I go along the grains, I'm helping to promote the lengthening of the tissues in and of themselves. Now, there's some super intricate finite details, and there's probably some various opinions and science to it, but that's just what my general research has come to indicate based off of these two direction types we could take in regards to muscle fiber direction in and of itself. Now, of course, the direction in which we travel to in regards to body parts, you know, it's another topic in and of itself. So, which leads into what we call the short strokes versus long strokes. So, as you can see on the second part of this picture, right, some strokes can be very long, some strokes can be very, what we're trying to do. And when would you want to use one or the other? Well, one, the general rule is to always follow the entire length of the muscle itself. So for instance, if we were working on a long muscle, let's say like the biceps muscle, of course we can go from elbow all the way to shoulder in one long swooping motion. Now, of course, if we were working, say, the rhomboids or the other interscapular muscles, maybe even the middle trapezius, our strokes would be pretty short. Our direction, or excuse me, our excursion would be relatively short and quick because of one, well, the space and limitation there. Now, also, depending on priority, right? So if we were trying to focus in one small area of the body, then we would prioritize that area. So for instance, if we were working, say, a trigger point or a muscle spasm or a cramp or something like that, our strokes would be very brief, even though even if we had a muscle that was really long, but we only had to work this small section of it, then our strokes would be very brief, because again, we want to prioritize in some cases, what is our focus, right? And we'll talk about that later on through the presentation here. So rate and rhythm is the next topic, or the next component of a massage routine, which is, how many times should a technique be repeated? And then more importantly, out of this concept is rhythmic versus arrhythmic patterning. Now, how many times should a technique repeated? I mean, as many as necessary, right? And if the client really likes that technique, then I'm going to ham it up. So in general, right, we say like increments of 3 or 5. So maybe do 3 or 5 strokes and then maybe change to another technique. And, if, like I said, if the client does enjoy that technique, then keep on keeping on. And then, and also we can, the other side of that coin would be, did we achieve what we needed to out of that technique? So maybe off of 10 strokes, didn't quite work. Maybe we'll try a couple 5 more. Now, there definitely would be a cutoff because we don't want to overwork a muscle, but you can try, give it the good old college try and see if that technique did in fact produce the results we wanted. And that's kind of going to go more along the lines of the benefits of massage when we look at what the individual techniques are causing in and of themselves. But and even then, right, so we can actually, time management, right, we can kind of incorporate that same idea into time management, right? So if we worked on that area with a few techniques and we did, an excessive number of repetitions with those techniques, and we spent a good amount of time, we might want to just let that area relax, right? Because we can't spend too much time in an area, because you can, in fact, overwork muscles or parts of the body. So we would, take a little vacation from that area, maybe go work another part of the body, and then maybe after about 5 or so more minutes, we can come back and try a couple more techniques and see if we can, achieve the results we're looking for, which, maybe it's to release a cramp or something like that. Now, rhythmic versus arrhythmic patterning. Well, I'm pretty sure you can understand that, well, rhythm is like a beat, right? If we had a metronome, 1, 2, 3, 4, 1, 2, 3, 4, that is rhythmic. So arrhythmic means lacking rhythm. So this would be like 1, 2, 3, 1, 1, 2, 2, 2, 2, 1, 1, 2. Very, very abrupt, very spastic, very irregular in a sense. Now, 99% of the time, all of our strokes just naturally are rhythmic, and typically the body favors rhythmic motions. Even if you think about some of our most abrupt techniques, such as tapotment or maybe even jostling, it actually still falls into a very relatively rhythmic pattern, which, rhythm typically is more favored by the body for several reasons, right? We have circadian rhythms, we have various rhythms. Our heartbeat is a rhythm. Cerebral spinal fluid flow is a rhythm. We have all these various rhythms in the body that we want to stay in on pace, on tempo per se, in the body. And so the rhythmic nature was also very calming and relaxing or stimulating of the parasympathetic nervous system. Now, arrhythmic patterning is going to be more jarring, more stimulating, more sympathetically engaging, and depending on if that's necessary, which is very, very few cases in which that is true, then maybe throw in some arrhythmic patterning, but probably not the most pertinent one. So then we have up next is the time management. Now, time management, again, is dependent on what the client's goals are, right? So if we want to, or if they want a full body general routine, then our time management is going to be spent relatively even in certain places. If they only wanted upper body, then we focus on upper body and divide up all of our time, right? Because as massage therapists, we're essentially selling time, right? You could either do a 60-minute, 90-minute, 2-hour, whatever, however you want to sell your minutes and increments and time. That's what massage therapists are technically selling. Now, of course, along that time includes, a beneficial massage and body work, but making sure that we spend the proper amount of time in an area to achieve the goals and effects in which our client is here and looking for. So if my client's condition or my client's concern was, increasing shoulder mobility because, let's say, maybe they, were in a cast for a little while and, now they're out and they've had, because of the lack of range of motion, they've been able to do, there's trigger points and stagnation that has developed in the muscles, and the muscles now have adopted new resting lengths. We want to try to coax them out of that pattern. So it's going to take time. And, you always want to explain to your client that has a focus, or a super specific focus, that by focusing on these areas and incorporating the levels of pressure, right? So if there's a really deep paraspinal muscle that I need to get to, it's going to take me a fair amount of time to get to that level with my pressure. And that time taken is going to take time from other areas. So, explaining that to your client during your intake process, which we'll take a look at in a moment, is very important. Time management too, also considering, like we said just a moment ago, that we don't want to overwork an area. So, dividing up your time, being logical with your time, don't spend too long in an area. You can always, leave and then come back to that area. And then sequence, right? Probably this is the fluidity tying all of this stuff together, right? Our sequence of techniques, right? We should have a logical progression from step by step, from area of the body to another area of the body. Our previous technique should lead to the next technique or lead to the next part of the body. Our, sequencing of pressure should be, like we said, light from deep, all that together. And so, that's what's going to make a massage really good, incorporating all of these components and the beneficial parts of those components into one fluid functioning routine. So moving into the next category, we have the client consultation and evaluation. A pretty straightforward and simple topic, but let's just go ahead and take a look at some key components involved in this section. So as the FSMTB indicated, effective intake skills I think I actually added that, right? Was the client consultation, verbal intake, health injury. Okay, that's what it was. All right, so what I perceive to be important out of this category is, of course, effectively, conducting an intake with your client. So what can we use, or what components or things we learned in this program help to create an effective intake procedure, an intake routine, or intake conversation? One, open-ended versus closed-ended questions should be pretty straightforward and pretty simple. Now, of course, we're going to use both in a conversation with our client as we're starting to try to be detectives, right? We want to have a bit of an interrogation, I guess you could say, of, why are you here? What goals are you looking to achieve? And is there any factors that can limit or help me get to that goal for you? Now, open-ended questions are questions that require our client to explain more of. So the difference, and then, well, closed-ended questions typically are very short, sweet, to the point, usually answered with a yes or no. A difference would be like, are you in pain? Yes, I'm in pain. That's a closed-ended question. Or, can you describe the pain that you're having? That's an open-ended question, because now they can say like, oh, well, it starts here, goes there, it's aggravated by X, Y, Z things, right? It allows for explanation and allows us to gather more knowledge around our clients' issues. So one personal thing I always suggest is to perform assessments during the intake, right? So I've done this time and time again, where let's say a client comes in and they're complaining about neck pain, shoulder pain, whatever, and then they say like it's stiff, it bothers them to move in certain directions, or they can't do full range of motion. So let's say like my client's like, oh man, I can't really turn my head to the right, it really bothers me. So I'll say like, okay, well, let's do a range of motion assessment real quick. Could you try to turn as far as you comfortably can to the right? I'm like, oh, that's it right here. I can't get any more. And then, okay, now turn to the left, please. All right, so try to remember those differences by the end of the massage. And so after the end of at the end of the massage, after the end of my routine, I do a post assessment with my clients. Like, okay, let's go ahead and check out that that neck mobility, that cervical mobility here. Could you look to the left again? All right, about the same as we had. Now look to the right, please. And then like, and when they turn, it's like magic. They literally witnessed full circle the benefits of that massage. So I highly implore you guys, both, not even just for taking the MBLEX, but in your practice and working with your clients, conduct these assessments with your client during the intake. And now I know sometimes you don't have as much time, but try to make that time. It's really valuable, I assure you. And it's going to, like I said, show immediate benefit to your client, and to potentially get you rebooked, right? Now, another aspect of this would be portraying that you care. I should have probably ran my spell check on this, but portraying that you care to your client, because they're coming here, especially those who are coming for massage to work on issues, and even those who just come to relax, they still want someone who is concerned for their well-being, someone who is taking their healthcare seriously, right? So how can we do that during an intake? Well, active listening, which is, making sure that you're attentive, making sure you're engaging in the proper amounts of eye contact, to make sure that you repeat what they said. It's usually a good sign of active listening, and showing to the client that you've heard and understood them, are all good ways in which you can try to make sure that your client feels confident that you have their best interests in mind. Creating a relaxing atmosphere and developing rapport. Of course, if our clients can't relax in our clinics, if they cannot be comfortable with us, then how are we going to get our point across? How are we going to have this massage benefit for our clients if they're on edge the whole time, right? So creating a relaxing atmosphere, again, goes to the previous topic of the way we talk to and communicate with our client, trying to make sure that our client is empowered by eliminating what we call power differentials. And developing rapport is rapport in and of itself is the bond in which that people have when concern is shown and respected and reciprocated from both ends. So by building rapport, essentially you want to build rapport with your clients of being able to just have your client instill trust, confidence, and I guess in a sense believe in you and what you're doing and your knowledge base, right? And sometimes that can also come along with, explaining to your clients, the procedures and what you're going to do, and getting into our next topic, informed consent versus implied consent. So let's use this in that current example of, me saying to my clients, like, okay, so if you want to work with the neck and shoulders, I'm probably going to have to work, say like around maybe the pec region. I might have to work around the other side of the body. So like, or for instance, like maybe my client with low back issues, I have to explain to my client like, oh, well, usually in cases like this, the pain isn't always coming from that specific spot. Now, of course, I will put a fair amount of work there, but with your permission, I'd like to, check on other areas and make sure there's no problems in those areas that could be contributing to this. So for instance, low back pain could be coming from the glutes, hamstrings, quads, abdominal muscles, right? So maybe with their permission, I can, inspect work on and see if there's issues in those areas. And that just shows confidence to your client that, well, one, you understand how the body works, you know your techniques, you know the body well enough to be able to help them, and that you were caring enough to ask them if that's okay. Now, the difference between informed consent and implied consent is typically what you'll find on your form. So on a health history or a health intake form, which we'll take a look at in a little bit, you might have a section on that intake form to list areas that the client's comfortable with receiving massage. Typically, those areas includes the abdominals, the glutes, the pecs, scalp, face, hands, feet, you know, pretty much anything that the client might feel uncomfortable with you working. So when that client checks the box yes next to abdomen or abdominals, that's implying to the massage therapist that the client understands what this is and is consenting to treatment. Now, implied consent is not as good as informed consent. So the difference is, informed consent is that the massage therapist has thoroughly explained what this is, and the client, to the therapist's face, has agreed and consented to, well, whatever it was, to the treatment, whatever, right? So typically, so same thing, right? Because I've had plenty of people fill out an intake form and they're like, what's the abdomen? It's the, you know, it's the stomach. I'm like, oh, I don't want that, right? So someone who might not have known might have checked yes, thinking, I don't know, maybe the abdomen was my pinky toe. And they're like, yeah, I like my pinky toe work, whatever, right? So now when I say to my client, like, oh, so you said that working on the abdomen is okay, which is the, you know, abdominal muscles here, the stomach. And they're like, oh, whoa, no, I don't know. I didn't know that's what it was, right? So now we've informed our client, and now they have the right to consent more properly. So we can take a look at a couple concepts that might help out client consultation and evaluation. There's a few methods of conversation that we might be able to utilize, which is the PPAW method and the Operquist method. So the PPAW method, it's an acronym, stands for purpose, which this kind of goes along like, what do you want to say, or what kind of questions do you want to ask your client during the intake? So purpose, you know, purpose or focus. Why is your client here? What do we need to focus on? What is the goal to achieve? Pain. Is the client in pain? Kind of helps along the lines of purpose. Does our client have any allergies or conditions we need to know of? Do they have any lifestyles activities that contribute to this or might help with this? And we can maybe align their treatment goals alongside their lifestyle activities. And then, of course, any medical or surgical information. So the Operquist method is a little bit longer and a little bit more detailed in the sense of symptomatic pain or issues that a client might be having. So first is the onset. You know, when did all of this start? So if they're having shoulder pain, when did that start? Provocation is what makes this worse. Is there anything that you do, any activities you do or don't do that cause this to flare up, cause this to be more problematic? Palliative, what do you do to make it feel better, if anything? Have you, and then in that regards too, have you ever tried massage therapy for this condition in the past, especially if it's something that comes up every now and then, something that's kind of recurrent or chronic? Quality, you know, describe the pain. Does it radiate? I think, yeah, which is the next thing, radiation. Does it radiate from area to area? Does it move somewhere? Is the pain intense? Is it really sharp and really jarring and debilitating? Is it just a dull ache? You know, what is it? Site, you know, where does it hurt? Obviously, right? We want to know what that is. And then timing, how often and how long do these episodes or does this pain last you? How often does it even return? Like how long or far in between do maybe constant reoccursions happen? Now, in general, for those who, you know, take their program with me, you know, and we go over the intake procedure, there's 5 questions in which you want to ask a client, right? First and foremost is, what brings you in for a massage, right? And that's going to help highlight essentially what we just saw here in these 2 methods. You know, why is our client here? What is their focus, right? 2, have you ever had a massage before? We want to understand what is their knowledge? What is their experience with massage, so we can help curtail their experience? For some people who might have never had a massage, might not understand the nature of massage or the proceedings of massage, I may want to hold their hand a lot more and be a lot more reserved with my techniques or my treatment plan, and some of the things I would normally do with a client who might be more experienced. Then, of course, we want to ask them if there's any areas that we need to focus, which includes any areas that might be painful, symptomatic, whatever. And then, of course, any areas that they don't want me to work. Would you like me to ignore working on the glutes if that's not something you're comfortable with? And then lastly, if you didn't already gather this from their intake form, is there any medical conditions that I should be concerned of? And then maybe I'll list out maybe some common ones that might be problematic for massage. So then we actually look at the health history intake form. What exactly should this consist of? Now, if you're making your own, then, probably look up a couple just to kind of cherry pick some of the things you like out of a few of them. Typically, they're going to have some of the standard stuff, which is the client's name, the date of birth, the contact information, all that normal stuff, because, we want them. I mean, how else are we going to know who they are and how to reach back out to them? Now, some of these optional things may be less optional as more is required, and depending on the person you are. But your address, contact information to me would be more like a phone number, but the address, emergency contact, arguably, part of the standards to go to, right, just in case something does happen. I would definitely have an emergency contact for someone who I might know to have issues such as like asthma, epilepsy, or just various other conditions that might take that person out, right? Or I might need to call someone for this person. Weight, occupation, all those potential things. Weight might be a little tricky to put on there. But I don't want them to know my weight, but sometimes it does help to have that on your form when if you're in a large spa with numerous therapists and they get a client, they're like, oh, this guy's 300 pounds. I might need to put my table lower or whatever, right? Occupation kind of just helps us understand their lifestyle, which can help us to develop our routine a little bit more. Of course, we're going to want on that form a list for common medical errors, or common medical conditions, and as well a section for them to indicate where any medications they may be taking, which then, of course, we have to do our due diligence to make sure we understand the concerns behind certain medications and massage therapy. Sometimes it's nice for them to have a diagram which they can draw on to indicate areas of pain, or just like a line or two where they can write down areas that they feel pain. And it's always comical when I have the little diagram of a person and it's like, please indicate on the diagram where you feel pain, and people just circle the whole person. So I'm like, okay. This is absolutely required, and depending on the legalities in your state, you need to have that disclaimer at the end of the health history take. So the health history form is not only just a medical record, but it's a legal, in a sense, contract between you and the client, that the client has read and stated that the information on this form is correct, and that they are providing their consent to be treated by you with this knowledge presented. Now, some things are, like I said, legally required depending on your state. Especially here in the state of Florida, we do have to legally put on there the right of refusal, which is to inform the client that they have the right to refuse service, and that's also held in reserve for the institution as well to refuse service. We also are legally required to place on that form or on that document the policies on draping, but as well as you can put all of your policies, and you arguably should put all of your policies on that or in that section regardless, right? So you can put your cancellation, late fee policies, payment policies, or rescheduling policies, your policy on there, because this is the CYA insurance. This is where your client should technically have read that, and then right below that is where they're going to sign their name saying that I have read above everything Everything that I've stated on this form is true. Nothing was left out. And if it was, so help you God, it's on you and not the therapist, right? So, you know, try to make that section as good as possible. Now, let's take a look briefly at collecting or writing SOAP notes and data. So now there's lots of ways for documentation. There's the APA method, there's the SOAPier method, there's the there's like 3 other that I forget, whatever. But SOAP is the most common and honestly the most simple, and really why use any of the others necessarily? So just a brief recap. Remember, SOAP is an acronym, not something you wash yourself with. So subjective, objective, assessment, and plan. Subjective data is essentially anything that the client says. Whatever the client reported to you, you're going to place that information in that section. Objective is anything you've observed through assessments or other verifiable means. So let's take a look at an example here. If my client comes in, they said they had a broken arm, then I'm putting in the subjective section that the client said they had a broken arm. Objectively, I saw they're in a cast and they had an x-ray of their broken arm dated, you know, 3-4 weeks ago. I'm going to assume that arm's broken, right? So objective, you know, verifiable information goes in that section. Now, assessment as a category for SOAP notes is a little bit more, it's probably the hardest section, because assessment isn't necessarily actual assessments. It's more of the methods that you used and the outcomes of those methods. So for instance, a client who might have wanted to increase shoulder mobility. Well, I use petrissage at these muscles. I use longitudinal strokes on these muscles. I did active resisted range of motion exercises with the client, and also the outcome, like we said. So like, okay, pre-analysis of range of motion at the glenohumeral joint was 70 degrees of humeral abduction. Post-analysis is that we've increased to, you know, 110 degrees of humeral abduction with scapular upward rotation too, because of, you know, scapulohumeral, really, whatever, right? So that's where we're going to put what we did and did it work. Then plan, you know, obviously is what we're going to do with our client for future sessions. Now, this is where we're going to rabbit hole a little bit, because we also had seen earlier in this section that we wanted to also be able to evaluate post sessions and progress. That's also going to affect our plan. Let's take a look at what should be in a proper treatment plan, which is clearly defined goals and objectives, and achievable goals and objectives, right? We can't just say like our client's going to be cancer-free with massage. Like, that's never going to happen. Or they're going to fly, or this like abnormal, like superhuman, supernatural things cannot happen, and we can't have that as a goal. That should be pretty self-explanatory. But we want to clearly define what our goal will be. So even in the sense of this guy with the shoulder mobility, or woman with the shoulder mobility, we want to clearly define that, okay, well, the client, you know, first session, you know, initial range of motion analysis indicated that there was only 60 degrees of humeral abduction, 0 degrees of scapular upward rotation. Okay, so after post-session, we've increased to 80 degrees of humeral abduction with 0 degrees of scapular upward rotation. Going forward, we want to increase that range of motion to 110 degrees of humeral abduction with 5 degrees of scapular upward rotation, because now we're, you know, getting a little more scientific, but whatever. So on top of that, we want to also write down the specific interventions or treatment modalities that we're going to use. What are you going to do to achieve those goals? What is the procedure? What is the techniques? What are you doing? What are you using, right? Diagnostics I think it's actually listed somewhere later. Methods to monitor progress and stuff, or also to evaluate, like, what are you doing to demarcate benefit? What are you using to justify the means to the end, right? A timeline for treatment, right? So that's really important too, that I want my client end goal within 4 weeks of regular sessions, of 2 times per week for over the next 4 weeks, to increase from a base level of 60 degrees of scapular or glenohumeral abduction to 120 with 15, 20 degrees of scapular upward rotation by doing XYZ things, utilizing the Petrosage, utilizing active resisted range of motion exercises, so on and so forth, right? And then, of course, also additional things could really help is like, well, what could you do in light of certain issues, foreseeable issues, which you can't always do. Those usually kind of come along with progressive treatment plans, which goes along the lines of how we were saying, to evaluate the post data information. And so it's like, okay, well, the client left with increased range of motion. They came back and said that their arm started to hurt more, and they actually lost a little bit of range of motion. And why did that happen, right? Well, what did we do? Maybe we tried it. We went a little too hard, too quick. The muscles and the structures of the body weren't ready for that. Maybe there's another underlying issue that we're not seeing, or it's not present, right? Maybe we refer them out for further analysis from another specialist, stuff like that, right? And so, your plan is the most complicated part because it requires such super sleuth, mentality to it, and a lot of trial and error. But it's also the most fun part of what we do. That's what I love, was just problem solving and just doing research for all these clients and all my patients, that it's like, well, what can I do to help you and get better and all this stuff, right? So when we write our notes, there's a couple rules for documentation that we'll just briefly mention. One, so this is obviously more specific to physical written documents or notes, which is to, one, only use blue or black ink, no fuchsia pink, whatever, right? Get that highlighter out of here. Single line cross out of a word or a mistake. Don't use correction tape or fluid, because that shows that you've falsified a document. If a single line cross out shows what the error was and why you fixed it, right? If you just fluid tape, who knows what you wrote previously and why you crossed it out. You could be falsifying that document, right? Do not use that. Make sure you use common abbreviations. Usually there's a key at the bottom of most files in order to do that, where you can look up some common abbreviations for SOAP note documentation, because obviously speed is of the essence when writing notes. So we want to write these notes as quick as possible. Now, in the instance of, let's say, the subjective section has 4 lines for you to write information and you only use 2 of them, put a line through the rest of the remaining space. Why? Because that allows someone to not come behind you and write stuff after you and, again, falsify a document. Then, of course, we want to make sure that we placate for HIPAA, which is in a section of itself. Remember, the Health Insurance Portability and Accountability Act. Sorry, it's HIPAA. Whatever, should do my spell check. Which is who safeguards clients' information and all that, and we'll take a look at that later. But make sure you use the double lock rule, that there's 2 points of access or 2 barriers to get through to get to a client's information. A locked file cabinet and a locked office is usually sufficient. Or if it's on a computer, there's a password to get onto the computer, a password to get into the SOAP note program, in a general sense. So then we have visual assessments. So first, let's take a look at the general assessments. A general visual assessment, for me, from what I could gather, right, would be something along the lines of just essentially a visual just generic visual assessment, something you're going to do with any client no matter what. Even if they just wanted to sit down, relax, and have a cup of tea, you're probably going to do these regardless, just to make sure everything's kosher. So making sure that we look out for areas of broken skin or rashes, any areas where there's sores, acne, or other general regional contraindications, areas of inflammation, right? And even their physical state during the intake. Do they appear tired? Are they anxious? Are they, super hyper, right? Super mobile, really ready for this massage? All of that can play through to help us, redirect and understand how we're going to proceed with our massage. Then we have compensatory patterns, or we call compensation patterns. Compensation patterns are a little bit complicated, but let's go ahead and just explain the generic understanding of what a compensation pattern is. A compensation pattern is where our bodies are going to adjust for either lacking something, or because of pain, or to essentially promote or alter the function of our body, again, and typically in regards to lacking something, or in the face of pain. Now, there are lots of different compensation patterns, and the prehab guys, one of my favorite people out there on YouTube, if they see this, hey, they have on their website a list of common orthopedic compensation patterns, such as like pronation distortion syndrome, stuff like that. So you can look up and Google a list of various compensation patterns, orthopedic compensation patterns, and that'll help you out. I don't want to get too far deep into this. I just want to explain what the understanding of a compensation pattern is. So let's take a look at some of these various assessments, namely, first off, postural assessment. So right here, you can just screenshot that picture there, or you can just Google it, whatever. This is what we call a visual analysis or static postural assessment that we can perform with our clients. Now, what that is, or how do we do this, is one, we typically have the client stand in front of either a grid or behind what's called a plumb line. A plumb line is literally just a piece of string with a weight hanging from the ceiling that's going to create a straight line. And then we have the client stand in front of that. And what we're doing with this, the purpose of a visual postural analysis assessment, is to identify symmetry, imbalance, and various compensation patterns. So out of this, we want to understand what landmarks are we looking for in regards to identifying balance, symmetry, so on and so forth. So there's essentially three positions, four in reality, of how we can look at a client, either from an anterior view, just like this guy is, from a lateral view, which there's two sides, two lateral views, right? So that's the four, that's what makes the four, and then a posterior view. So when we're looking at a client from the front, what landmarks are we typically going to be looking at for levelness? Well, typically we can look at the ears, we can look at the eyes, we can look at the clavicles, we can look at the apex of the armpit here, we can look at the base of the ribs, we can look at the top of the iliac crest. The ASIS is also a big landmark for this. The hips, knees, ankles. So typically we want that typically the knees should line up relatively underneath the hips. Our clavicles and everything should be level. Our spine should be relatively straight. With the spine, we'll take a look at a posterior view, right? So what things could we identify potentially with an anterior postural assessment? Well, one, we can recognize tilting of the tilting of the hips, unevenness of the hips. We can recognize, say, like scoliosis, probably better from a posterior view, but like a lateral curvature of the spine to a degree. We can recognize if one shoulder is higher than the other. We can recognize maybe a potential leg length discrepancy. Or we could also look at valgus versus varus, right, of the knees or of the elbows. So varus is where we call that bow leg, where the knees, I like to say, are far from us. Varus, far from us, is the bow leg, and then valgus is where the knock knees are coming together. And then it basically for varus, valgus of the arms. We could also see pronation distortion syndrome, which is where essentially you're riding on the outside of your foot, stuff like that. Just to name a few. From a lateral view, we could potentially see rounded shoulder posture, kyphosis, lordosis, right? Cervical kyphosis even. From a posterior view, pretty much the same thing as the anterior view, probably arguably a little better for scoliosis and other various means. Well, yeah, let's list the landmarks of a lateral view. One, we want to make sure the ears line up with the shoulders, right? Because if it's forward, that's forward head posture. We also want to make sure that the shoulder itself isn't too far forward. Again, we can look at the ASIS versus PSIS to identify posterior or anterior tilting, hip, knee, and ankle as well. From the posterior, we have the external occipital protuberance, superior nuchal line. We have the entire spine. The shoulder blades should be relatively held back, roughly towards the spine itself. We have the iliac crest, PSIS, knees, ankles as well. So the next assessment is a gait assessment that we'll take a look at. Now, I'm not going to go into a whole bit of detail about all the various conditions and so on and so forth. I'm really just going to explain the various parts of a gait cycle and maybe identify where things might be off. So first, the gait cycle is measured from, as indicated in this image, it says initial contact, or what we call heel strike, the strike of the heel. The heel hits the ground of one foot to the same initial contact of, or heel strike of, that same foot. So we have the initial contact or heel strike. We have the toe off of the opposite foot. We have the swing phase here, as we have single leg support and the leg is now crossing over for the heel strike of the opposite foot, toe off of the same side foot, and then essentially it just repeats on the other side towards the initial or next heel strike. So what are we looking for in a gait cycle? One is we want the arms to swing opposite of the legs. So if my right leg goes forward, my left arm should go forward, right? Because that's going to create locomotion. We want the shoulders to roughly not move a whole lot. And then we're going to look more for movement of shoulders as in like up or down. Like I shouldn't be like, gyrating my shoulders as I'm walking a whole lot. Where you're actually going to see that gyration is in the hips. And our hips should make a figure 8 pattern, right? As we're moving. We should have some slight knee bend as we swing our leg forward. We should have some slight bend to the knee, and we should have dorsiflexion of the foot to engage heel strike. So those are our main components of what we'd be looking for to identify if gait is improper. So Palpation assessment. Palpation, of course, as we know, is the assessment of various parts of the body through touch. So what exactly can we identify and assess through palpation? Well, we can identify the tissue texture. So in regards to what tissues feel like, right? Adipose tissue should be soft, spongy, maybe even a little like cottage cheesy, depending on it. Your muscle tissues should feel, relatively dense, should feel, but still soft and spongy to a degree. We'll talk about tonus in a moment. And connective tissues, like in the names of tendons and ligaments, should feel, pretty rigid, pretty dense, and maybe even fibrous. Of course, we can detect tissue temperatures. We can palpate if things are tender. We can palpate if things are swollen as well, such as like lymph nodes, or if there's edema in an area, right? We can feel if it's a lot more like liquid, spongy kind of feel. Not what we're going to probably do. This is more of like, a doctor, but organ location and size. But I guess, lymph nodes too, if your client might be feeling a little ill, you can do some sort of lymph node palpation, especially if you're doing like lymphatic drainage. Consistency in regards to the firmness or the softness of the tissues. Presence of masses of lumps, right? I mean, if you're working as a massage therapist, you've probably felt some weird things, and your client's like, "Oh, that's just a fat pocket or a lymphoma or something like that." But sometimes you might want to find, if you find some odd lumps, bring it up to the client, bring it to their attention, like, "Hey, this was there?" Muscle tone, which we were just mentioning a moment ago, right? We can palpate and feel, is a muscle like super contracted? Is it hypertonistic or is it hypotonistic? Meaning is it super contracted or is it rather flaccid? We can detect pulses. Crepitus, right? We can feel the popping and creaking and cracking of the joints. Of course, joint mobility in and of itself, which we're going to take a look at here in just a moment with the range of motion assessments. And obviously, if we can provoke pain to the touch, like, ooh, oh, that's it. Ah, that hurts, right? So that's all part of our palpation assessment. And what that leads to and means, various things, kind of goes along with our pathology section though. So let's take a look at range of motion. Two parts that we're going to look at for range of motion. This should be the end of our long video here, is coming to be. So range of motion, as we all know, is to move a joint through various ranges of motion. One big part of range of motion is denoting the end feel of the joint. So what exactly is end feel? Well, end feel is labeled as what it feels like when the joint's range of motion finished or ended or stopped moving, right? So there's three main categories with several subsections, I guess you could call it, or classifications within them. So we have a physiological barrier. Physiological barriers are a range of motion that is typically caused by the soft tissues or other tissues that are literally just, they're the physiological components of the body that are stopping or preventing movement. So we can have two types. We can have a normal, or what we call a hard, or, well, excuse me, I guess that's labeled in the anatomical, sorry, or firm end feel. So a soft end feel is where soft tissues have stopped you. So a common example is if I bent my knee to where my heel was coming towards my glutes, and if my calves are so big and my hamstrings are so big, or I have lots of tissues there that it stops the movement, then that's what we call a soft end feel. So, because normally our range of motion or the space allotted in those joints should allow us to bend the knee all the way back, and the heel should very easily hit the hip socket, or excuse me, not hip socket, but hit the glutes in and of themselves. So if we have soft tissues that are stopping that, then that's a soft end feel. We could also have the firm end feel, which is caused by other structures, namely the joint capsule or the tendons or the ligaments or other structures that just don't have that necessary range of motion, don't allot for the permitted degrees of movement. Then we can look at the anatomical barriers here, which anatomical barriers are caused by, well, the anatomical structures in place, which kind of, I mean, physiological versus anatomical, almost the same thing. So we have what's called hard end feel and anatomical barriers, which is just like my elbow. I can't extend my elbow any further because bone on bone contact has occurred to prevent that movement. Then we have pathological barriers, which are caused by, well, pathologies or complications in the joint themselves. So in this case, we have, you know, abnormal end feel, which is labeled as the traditional pathological end barrier, which is caused because of, let's say, defects, right? Maybe the shape of the joint, shape of the bones, or another condition such as arthritis, or maybe there was a previous break or you know, previous luxation before. Something along those lines is causing an issue. Or an empty range of motion, which is where the joint experiences pain somewhere and causes us to stop moving the joint any further. Then technically, we could also look at the various modalities, namely the, you know, P&F stretching or muscle energy techniques that are going to allow us to increase range of motion or increase the resting length of muscles. So I won't go into detail on that right now. Just probably do that in a separate lecture, just because, and with demonstration, I think that might be an easier way to go with that. Now, one concept I do want to touch on in regards to range of motion is the idea of goniometry. Goniometry is the measuring of the movement of joints in degrees of motion. So like we said, range of motion, right? Well, what exactly is the range? Well, it's the actual degrees of movement that are occurring. So as you can see here, these are typically performed by measuring with what's called a goniometer, which, I mean, you can see the picture in this case is a guy standing in front of what looks like a protractor. So remember, just a quick brief explanation of this. I know we did already kind of talk about that in the previous video, that we always reference these movements from anatomical position and our starting point. So if I put like a protractor here with like the U down, this is, you know, straight down 90 degrees, you know, or in this case 0, start raising it out to the side. If I make a 90-degree angle, right, I've now made a right angle from the initial position to where it is now. And so, yeah, like I said, you know, it's a very rabbit hole concept, but just having a general idea of what the starting point is. So like, for instance, if I wanted to do my shoulders here, if I wanted to do 180 degrees of shoulder flexion, 180 degrees of shoulder flexion is raising my arm completely over my head. Now, our last topic here, our last concept is essentially tying this all together, which is clinical reasoning. And it's going to involve all the other parts of the program, all of the other various sections as according to the MBLEX, right? The ability to rule out contraindications, right? By understanding the benefits and effects of massage, which is another category of the MBLEX, right? Alongside the pathologies of the body, right? Then we need to, in a clinical sense, rule out like, well, do these two things line up? Can they be beneficial to each other? Or do I have cause for concern to either avoid doing this or either avoid the massage completely and refer the client to a specialist? Client treatment goal setting, as we already discussed already, the ideas and concepts of developing a treatment plan or the components of a treatment plan, right now it's up to you to utilize the understandings of the benefits of massage, ruling out the contraindications, and understanding your clinical reasoning and justification to create a proper treatment plan that's going to align with your goals and be your client's goals and be achievable. And then, as we said, the evaluation of the response to the previous treatment. progressive, because just because you wrote a treatment plan doesn't mean that's what you're going to do. If you wrote a treatment plan a month ago for this client and they came back a month later, you're not going to follow that to a T if things have changed. So you need to be dynamic, and you need to be able to update and adjust accordingly. And then, of course, explain to your client the new circumstances, the new adjustments, and what you're going to do in that session in itself. And then the formulation of a treatment strategy, which seems to kind of just go along together. Like I said, tying it all into one big thing in order to make your client nice, healthy, and happy. So probably some minor things out there, but I think that's going to hit pretty much the nail on the head for this category, and at least give you some of the biggest things. Now, so I will say some additional topics to study would be to maybe look up some more orthopedic assessments. Now, I know in chapter 14 of this book, there is like the Apley scratch test. There's, the open, full can, empty can test. Some of those orthopedic tests might be beneficial. And then, like I said, I'll probably do a separate video on it, but in the meantime, you can also look up PNF stretching, muscle energy techniques, and understanding the procedures and purposes of those. But I'm going to go ahead and call that for tonight.